Thank you, Corey. Good morning. This is my first talk at CCFA as a member of Mount Sinai. I'm very proud of that, and I will try to perpetuate Lloyd's legacy. So, what is comparative effectiveness research? You have these different points on your slide. I just would like to insist on the last point, because basically this is a kind of very short summary. The two key elements of comparative effectiveness research are the direct comparison of effective interventions and the applications of these interventions in patients who are typical of day-to-day clinical practice. So this is clinical care. Why do we need comparative effectiveness research in IBD? Because I'm sure that you are also convinced that there may be a difference between clinical trials and clinical practice. Clinical trials, you have a very well-defined population, a prescribed treatment regimen. You need a follow-up, very regimented, uniform primary endpoint, and this is talking about efficacy. Comparative effectiveness is clinical practice, heterogeneous population, a variable treatment regimen with the possibility of optimization that you are doing in your regular practice. Follow-up is not fixed, variable outcomes, and this is effectiveness. So this is an interesting study done at Mount Sinai by Christina A. and Asher Kornblut, because they had already this feeling that maybe patients in clinical trials do not always reflect their clinical practice. So this is a retrospective study of patients with moderate to severe IBD, and they were asking the question of all those consecutive patients, do they meet all the criteria to be included in clinical trials? And actually 1/3 of patients were not eligible for various reasons that are detailed on this slide, both for Crohn's disease and for UC. And the non-eligible Crohn's disease patients had a significantly lower response rate to biologics than eligible Crohn's disease patients. So in other words, that means that the data in clinical trials may not always be applicable to clinical practice. So comparative effectiveness, still, I think it's very important, and these studies will change our practice. And actually, the SONIC trial is a comparative effectiveness trial, because we compare azathioprine monotherapy, infliximab, and combo therapy. And this is a kind of study that has strongly changed our current algorithm of the treatment of IBD. So what are the priorities for comparative effectiveness in IBD? This is a very interesting study published in 2012 in the IBD journal, and this was a result of an international survey, expert round panel, and patient focus group. And you have on the right-hand side the list of top 10 questions that should be answered in the next future. I will not detail that because I will give you my point of view, but just to make the point that two of those studies, such as the cyclosporine against infliximab study, have already been done, and so the data are already available. So my view of the most important unanswered question is very simple. I see a treatment of an IBD patient as a journey, as a flight. And then there are questions about takeoff, about flying, and about landing. And please note that I'm still flying Air France because the food is much better. So what about takeoff? The takeoff, of course, now we have many biologics available. And I think this is a very important question that I'm posing in clinical practice like every day. Which one to pick up? And we could compare the biologics and the anti-TNF. We have the three little pigs. And maybe it's worth to compare these different agents. And actually, there are some data. This is a very interesting study, retrospective cohort of US Medicare, looking at adalimumab and infliximab. And as you can see, the primary outcomes were at week 26, persistence under treatment, surgery, hospitalization, and bottom line, there was no difference between any of these, between adalimumab and infliximab. So, but now we have a new player on board, as we heard from Steve and from Bill, and this is vedolizumab, amazing data, especially in UC. So, Steve, I think that this is time for comparative effectiveness trial, we need to compare one of the 3 little pigs with a big bad wolf. But of course, this will not be easy. And actually, it's very interesting to note that according to the US Institute of Medicine, this is a top priority that we should seek in IBD, which is to compare the new biologic agents. So let's do it. Very interesting question as well, that very often in clinical practice, you have a patient coming to your practice with a short, small bowel affected segment with the question, should we go to surgery or should we treat this patient with biologic? And this is the goal of the LYRIC trial, which is currently ongoing in Netherlands. So a patient with Crohn's disease, with only the terminal ileum affected, will be randomized to laparoscopic ileocolite resection or infliximab. So this study is ongoing, and we are looking forward to this result, because I think this will answer a very important question as well. What about combo versus mono? Some in the audience will say the game is over. Combo is superior to monotherapy. And this is based, once again, on the only prospective study with azathioprine and infliximab, which is a SONIC trial. Still, a recent meta-analysis presented at DDW this year in 2013 has actually shown a strong impact on combo therapy as far as efficacy is concerned for infliximab, but no impact for adalimumab and certolizumab. I want to be very cautious about this study because this is retrospective data, the only prospective data so far as with infliximab. Still, I think this question is always posed in clinical practice, and I think we need to answer this question in prospective studies. I think we still need to understand much more about combo therapy because there are some very puzzling results. This is a very interesting result from COMET by Brian Figan, and what they did was to compare infliximab plus methotrexate versus infliximab alone. And as you can see on the top of the slide, the primary endpoint was failure to enter steroid-free remission at week 14. And there was no difference at all. So combo therapy in that setting was not superior to monotherapy. But what's very important to observe is that this is the highest success rate ever observed with any kind of treatment. When you look at week 14 and week 50, up to almost 80% were in steroid-free remission in both groups. And it's very important to note that all patients were also induced with steroids. So we may ask the question, maybe the best combo therapy to use is actually a triple therapy with steroids and anti-metabolite and biologics. So I think this question should be addressed as well. What about step-up versus accelerated step-up versus top-down? This is a very interesting review paper where you have a very nice figure illustrating the 3 different strategies. The classical conventional step care approach, the accelerated step care using azathioprine upfront, and the early top-down with the biologics. These 2 studies have been shown by Bill. Basically, there was no difference between azathioprine introduced at diagnosis or azathioprine on demand in the RAPID study or in the AZTEC study. There is one study, the classic step-up top-down studies that has been done with infliximab, and actually the primary endpoint of this study was negative. There was no difference between both groups, but it's very important to note that in that study there was no regular maintenance infliximab. So I think we need still to answer this very important question. What is the most important approach, and should we use a kind of top-down or accelerated step care? This is why we are waiting the results of this very important study, which is called REACT-1, which is led by Brian Figan. It's a very original study because the question is great. Should we use a usual care, classical step-up approach, or an accelerated care? And the second originality of the study is that it's a cluster randomized trial, meaning that they are randomizing not patients but practices, meaning that some practices are using accelerated care and some practices usual care. Just this slide to show what is the accelerated care algorithm, and to make this long story short. So patients who are included for active luminal Crohn's disease are treated with steroids, and very early at 4 weeks, if they are not responding, adalimumab is introduced with combo therapy. So it's a very accelerated step care approach as compared to the usual step care. And we are waiting for the results of that study. I think it will be presented at ECHO next year. What about the question, so now you have started, what should we do when you are on flight? And this is a question that was also posed by Bill, should we treat to mucosal healing? We have very interesting, but I must say post-hoc data showing that mucosal healing may be important for long-term outcomes, but we still need to do the prospective study. And this is a REACT-2 study that is led by Bill in the US. Once again, the same principle. Practices and not patients will be randomized to enhanced care treatment algorithm or step care treatment algorithm. And the enhanced care algorithm, basically, the treatment of the patient will be guided by endoscopy, meaning that following the initiation of combo therapy, if there is no endoscopic improvement, then the patient will be step up. So in one arm, the patient will be step up just on clinical symptoms. In the other arm, the patient will be step up on endoscopy. And I think this is the question to be answered. What about treat to biomarkers? Because it's not easy to repeat endoscopy in clinical practice. So should we treat to biomarkers versus treat to symptoms? This is very interesting data from the STORY trial. Just to remind you that in the STORY trial, we took patients on combo therapy and we stopped infliximab, and patients were maintained on azathioprine. And very interestingly, this is a study, a sub-study of STORY, looking at calprotectin levels in the group of patients who eventually relapsed as compared to non-relapsers. And up to 6 months before the clinical relapse, calprotectin started to increase. So maybe by monitoring and by treating to calprotectin levels, we'll be able to treat patients much earlier in their course. So this is why we have designed this study, which is currently ongoing, which is a CALM study. So this is a study, sorry, one back, please. This is a study of patients naive to immunomodulators and biologics. They are all treated with prednisone, and they are randomized to a conventional arm where step up is based on clinical symptoms alone, and the tight control arm where step up is based on clinical symptoms and biomarkers. This is a tight control arm, which may look quite complicated, but basically at each time point from week 9 to week 45, in this tight control arm, the patient is step up based on CDAI, CRP, and Calpro, meaning that even if the patient is doing well at a visit clinically, if CRP is still high or calprotectin is still high, we step up the patient. So this will answer this question as well. Should we treat to trough versus treat to symptoms? There are a lot of data, but once again, it's mainly association and post-hoc data showing that drug levels matter because they are associated with outcome, that antibody status is not directly associated with outcome, but is associated with loss of response, that dose escalation can increase drug levels, and that immunomodulation can decrease antibody production. But the question is still open. Should we treat to trough or should we treat to symptoms? And actually, we have now some prospective studies. The TAXID study will be presented later on today. And this is a very interesting study coming from Scandinavia. And they took patients who were secondary infliximab failure, and they were randomized to dose intensification, so just 5 milligrams every 4 weeks, or they were optimized based on serum trough level and infliximab antibody levels. So one arm was basically blinded to trough and antibodies, and the second arm was guided by pharmacokinetic data. And on the left-hand side, you have basically the difference between the two arms, and there was no difference at all as far as efficacy is concerned. But look on the right-hand side, this is a cost, and the cost of the trough and antibody-guided algorithm was much lower than the mere infliximab intensification. There is this important study also ongoing in France, which is a Taylorix study, looking also at the role of trough levels. So this is a study in a naive patient with luminal Crohn's disease who will be started on infliximab, and following week 14, on one arm, which is on the right-hand side, the patient will be step up, meaning the infliximab will be optimized just based on clinical symptoms, and in the two arms in the middle, the patient will be optimized, even though he's doing clinically well, but if the trough levels are under a certain level. So this will also answer this question: should we treat to trough? Should we try to optimize a patient who is doing clinically well, but in whom the trough levels are low? And finally, I want to talk about landing, because I believe that de-escalation strategies are very important to explore. We know that when you have a patient on combo therapy, you can basically stop the azathioprine or methotrexate or stop the biologics. This is a result of the IMI trial from Leuven, where they took patients on combo therapy and they stopped the azathioprine. This was a superiority trial, and actually it was a failure because there was no superiority of continuing the combo therapy as compared to infliximab monotherapy. But it's very important to note on the right-hand side that there is still a question mark about the long-term impact, that the trough levels of patients who continued were higher than the trough level of patients who stopped the immunomodulator. What about stopping the infliximab? This is a result of the STORY trial. So this is a study where we took patients on combo therapy, maintained on azathioprine, and infliximab was stopped. And I'm sure you know the data, because basically when you look at this curve, it's not so good, because 50% of patients relapse within 2 years. But interestingly, we were able to come with some models, some predictors of relapse or non-relapse when you stop infliximab. And to make this long story short as well, if you have none of the deleterious factors on the left-hand side, then you belong to the upper part of the curve on the right-hand side, and then your risk of relapse when stopping infliximab is low. I still believe that this kind of de-escalation strategy needs to be explored. This is why I hope next year we will start in collaboration between CCFA, JETED, and the Swedish group, what we have called the SPARE trial, which will be a control study where we'll be taking all patients on combo therapy, infliximab and azathioprine, remission, no steroids, and they will be randomized to either continuing the combo therapy, stop the azathioprine, or stop infliximab, and we have various rescue therapy in all arms. So I believe we need to do this question, because this is one of the most frequently asked questions by our patients. Okay, I want to start, but tell me about stopping as well. So to conclude, I think this comparative effectiveness research in IBD, this is our challenge. We need to do it, but it's not easy, because the design of these studies is complicated. The recruitment of these studies will be complicated as well, and I think it goes through international efforts, and the funding as well will be a problem. But I think it is our mission, because I believe that the results of these comparative effectiveness studies will improve the care of our patients. Thank you.